Well, it's a very hard act to follow. I mean, Maria's talk was just fascinating, and the update in terms of the new developments in progress of systemic therapies for thyroid cancer were there for all to see and just so eloquently presented. So what I'll be talking about will be the aspects of redifferentiation and the clinical trials that support that line of therapy, and I'll discuss some of the nuances involved with this. This is work primarily done by a very large team that I'll be outlining towards the end, mostly led by Alan Ho. And some of these slides actually are slides that he gave me. But maybe we should begin by recapitulating information that you've heard throughout this meeting and that relates to the genetic events involved across all stages of thyroid cancer that involve mutations of receptor tyrosine kinases or of RAS or BRAF, the activation of the MAP kinase pathway, which activates tumor proliferation and survival, but in addition suppresses the expression of thyroid differentiation genes. And as you know, these are critical for iodine uptake and retention, which I will not recapitulate here, but here you're seeing a prototypical thyroid cell with its receptor for TSH, and that drives iodine incorporation, organification at the apical surface, and then ultimately the endocytosis of thyroid hormones and secretion into the circulation. And this is the process that essentially is also required for radioactive iodine to be incorporated into cancer cells in order to deliver a therapeutic benefit. I outlined yesterday that there's a long history of work done by many groups that led to the insights that connect the activation of MAP kinase signaling to loss of differentiated function. But the one that was, I guess, immediately preceded the clinical trials was this study in which mouse were engineered to express BRAF V600E in the thyroid in a doxycycline-inducible manner. And when BRAF was on, it induced very rapid transformation of thyroid cells. And you could see in this time course of expression of the various thyroid differentiation genes that 1 week after activating BRAF, you already have suppression of all the thyroid lineage transcription factors and of expression of the thyroid-specific proteins, including the sodium iodide symporter. But when you discontinue doxycycline and allow BRAF then gradually to be shut off, then you get a restoration of expression of these genes, telling you that this is a reversible process. And it is also reversible with drugs, so that if you have mice that have BRAF expressed in all thyroid cells and you treat them with a MEK inhibitor, you can restore iodine incorporation, and you can also do so with a RAF kinase inhibitor. So this was the work that preceded the first in-human study that was done with this first generation MEK inhibitor called selumetinib. It was a study of 20 patients, and of which 12, when they were given a 6-week course of selumetinib, and we repeated iodine scans. We did them at baseline and then repeated them while the patients were taking the drug. What we found that 12 of them had increased I-124 incorporation into their index tumors. And of these 12, 8 went on to receive a therapeutic dose of radioactive iodine because they met a pre-stated dosimetry threshold that allowed us to predict that they would have a response. And then when we looked at the response, we found that it actually varied based on the genotype. So that BRAF mutant patients, of which 9 patients of the 20 had BRAF V600E mutations, we did get some degree of reinduction of iodine incorporation, but only 1 of the 9 patients met the threshold that would predict that we would get a clinical response. However, of the RAS mutant patients, all 5 patients met the threshold and were treated. And those that had other mutations, they were intermediate between the two. And some of these did have RET fusions. And this is the plot of the RECIST response in these 8 patients that did receive radioactive iodine, and the genotype is also indicated here. And interestingly, the BRAF patient that did respond had a pretty profound response. And here are the others. Most of these, as you can see, had NRAS mutations. So overall, there was a quite decent response. All of them had a reduction in tumor size, some of which was confirmed, which are those shown in the clear bars. And so this was essentially the proof of principle study that told us that this line of investigation had some promise. Now, subsequent to that, even at that time, when we were starting to get the evidence that this could be a viable strategy, we had discussions with AstraZeneca about trying to move this concept into the adjuvant setting. And we took advantage of the fact that Mike Tuttle had done very large retrospective analysis of our patient population and that of others to predict what the remission rate would be in patients with relatively high risk of recurrence, where what he predicted was that 30% of patients would actually enter remission. By that meaning, no either biochemical or structural evidence of disease. And so we included in this study patients who were considered to be at high risk of primary treatment failure. And that was patients with a tumor greater than 4 centimeters, or that had gross extrathyroidal extension, or N1A and N1B disease with at least one lymph node greater than 1 centimeter, and or with more than 5 lymph nodes involved. And the study randomized these patients 2-to-1 for selumetinib versus placebo. They were given selumetinib for 4 weeks to start with, which was the time required to resensitize them, and then they received a fixed dose, 100 millicuries of iodine-131 after preparation with recombinant human TSH. They were then continued for an additional 5 days on selumetinib, and then they were followed up through 18 months for the primary endpoint assessments. And there was a final follow-up that has not yet been completed to be done in 3 years. So the study was recently published, and as many of you know, it was a negative study in that the patients who had selumetinib had a remission rate of 40%, versus those that had radioactive iodine had a similar remission rate of 38.5%. So when we started to break down these findings to try and get at least some hypotheses as to what potential future directions could be taken in the adjuvant setting, what we noted is that there were problems in the design of this study, and that many of the patients who had toxicities with selumetinib did not take them, or did not take the full doses, particularly in the 7 days that preceded the therapeutic administration of iodine-131. So when we excluded those patients that were not compliant over that period of time, we did see a signal of benefit with selumetinib versus placebo, which of course was not statistically significant because the study was not powered for a change of this magnitude. Concerning the issue of BRAF mutations, not all patients were genotyped, and they were certainly not genotyped comprehensively. But when we looked at those patients that had BRAF mutations, there was no difference between the groups, whereas those in which BRAF mutations were not detected, there was a trend towards benefit with selumetinib versus placebo, again, not statistically significant. So in summary, what we learned from this, well, first of all, this was the first prospective study that allowed us to get a true evidence of what the remission rate is in this patient population, which was found to be 38.5%. So this is the expectation that, and what we already know, that actually more than 60% of patients that treated with radioactive iodine that present with the characteristics that I mentioned actually will not go into biochemical and or structural remission. Now, this study was ambitiously powered to design to detect a 20% difference between the groups, which of course was very ambitious for an adjuvant trial, because if you think of other adjuvant studies in cancer, such as those looking at the role of tamoxifen in ER-positive breast cancer, those studies have always been powered to detect differences in the order of 10% or less. So this was quite an ambitious goal. And then the subgroup analysis, as I mentioned before, suggests that treatment compliance obviously is critical in the window before the radioactive iodine is administered. And then the key importance of tailoring the drug that is used to the genotype. And this is what I will try and focus in the rest of my presentation. So the reason for that is essentially that the potency of target inhibition really matters. So let me begin by just showing you this in a very simplified reductionist system, which is looking at a cell line, in this case the PCCL3 cell, in which we've engineered a BRAF mutation that is only expressed when we treat them with doxycycline. So here you can see the doxycycline induction of BRAF V600E, and then we treat them with a combination of RAF and MEK inhibitors at various doses, increasing doses. And you can see that in terms of the effects on the sodium iodide symporter, that as you inhibit the ERK pathway, the MAP kinase pathway, more profoundly, you get your maximal restoration of radioactive iodine, of sodium iodide symporter expression only when you block the target profoundly. And that's illustrated here in this relationship between the ratio of phosphor-ERK and the expression of the sodium iodide symporter. This is also true in vivo. So in this case, what we've done is we've compared selumetinib, which was this first generation MEK inhibitor, with this other inhibitor initially developed by Chugai Pharmaceuticals, which we abbreviate here as either CH or CKI. This is now a drug that's been purchased by a company called Veristem, and they are actually moving this into clinical trials that we're going to be involved with. They are quite different in how they act. In that selumetinib actually, although it does bind to MEK, it's an allosteric inhibitor, it actually results in a rapid reactivation of MEK for reasons that I can't get into in great detail, but essentially it doesn't also inhibit the ability of BRAF to reactivate the enzyme. By contrast, the Chugai compound is also an allosteric inhibitor of MEK, but it inhibits the RAF that's bound to the complex, both the mutant and wild-type RAFs. So it really prevents the activation of the pathway as well as the feedback mechanisms that could result in bypass events. So what we looked at is in a mouse model of BRAF-induced thyroid cancer, to what extent these different drugs inhibited the MAP kinase pathway. And just to make it simple, what we're looking at is here two transcriptional markers of MAP kinase activation. And as you can see, the maximum dose of selumetinib that was used inhibited the MAP kinase output by 70%, whereas the Chugai drug inhibited by 85%. So a relatively modest decline in the total inhibition of the pathway, from 70% inhibition to 85% inhibition. But that relatively small change resulted in a spectacular difference in the expression of the sodium iodide symporter, so that the Chugai compound restored the expression back to wild-type levels, whereas the selumetinib only did so partially. And this is also true for other thyroid-specific genes, pointing to the true relevance of blocking this pathway profoundly in order to get complete redifferentiation, or as complete as feasible. So based on this, we try to move away from MEK inhibitors for BRAF mutant disease. So if you have a BRAF mutant cancer, as you know, it results in activation of MEK. But when you use a MEK inhibitor, you really have a relatively low therapeutic window, because MEK inhibitors certainly inhibit the pathway in the tumor cell, but they also are inhibited in normal cells, and that results in toxicity. By contrast, because BRAF V600E functions as a monomer, there's this paradoxical effect of using RAF kinase inhibitors, which do block very nicely the activity of the pathway in tumor cells, but actually paradoxically activate MAP kinase signaling in wild-type cells, so that the therapeutic window is much greater and toxicity is diminished. So it makes sense, because you can then use higher doses of the drug to block the pathway. So Laura Dunn did this study at our institution, where it was a pilot study and of 10 patients altogether that were treated with vemurafenib. Again, the protocol very similar. So these patients received 4 weeks of drug before repeating an I-124 scan. And you can see examples here of one patient who had a tumor that did not trap iodine-124 at baseline, did so after 4 weeks of vemurafenib, and then after treatment had a significant structural response. Altogether, whereas with selumetinib, one of the 9 patients with BRAF mutations had a partial response in response to radioiodine therapy. In the case of vemurafenib, it was 4 of 10. So it clearly, a small series, but clearly a trend towards better results. In this particular case, we actually also biopsied the lesion. So we wanted to learn as much as possible from these patients. So what we did is we biopsied the index lesions at baseline and while the patients were on drug. And what we did is we actually measured the MAP kinase transcriptional output score, or the BRAF-RAS score. Both of these show similar things. And on the other hand, also an enhanced thyroid differentiation score. So if you look at patient 6, which is shown here on top, you can see the very nice, reactivation of iodine incorporation with an SUV of 31.7 on the I-124 PET scan. And this patient had a nice inhibition of the MAP kinase transcriptional output. They were BRAF-like to start with. They became RAS-like while on the drug, and they had this robust reactivation of the thyroid differentiation score. This patient, who had an intermediate SUV uptake in response to the redifferentiation approach, also had an intermediate response in terms of the MAP kinase inhibition and the switch from BRAF to RAS, and also in the reactivation of thyroid differentiation score. Whereas the tumor that responded the least also showed the lower thyroid differentiation score upon treatment. So the other issue is, as you know, although selumetinib is a drug that's been around for a long time, it has eventually been approved, for treatment of other conditions, but not of thyroid cancer. There are several reasons to believe that this is a less effective MEK inhibitor. And without going into the biochemistry, which is actually described in the paper here below, we do know that trametinib is a more potent inhibitor of the pathway. And so this is a study that's unpublished so far, which essentially had 2 cohorts, one of 25 patients with RAS mutant disease, a second of patients who were RAS wild type. And these patients, in the same way, had serial I-124 PET scans at baseline and while on drug. If they met the I-124 dosimetry threshold, they received radioactive iodine treatment while still on trametinib. And the primary objective was PFS at 6 months, an overall response. And so this is the summary of the findings. So of the 25 patients that were treated, 22 actually showed increased I-124 uptake. And the ones that were eligible for therapy were 15 of 25, that's 60%. And this is their RECIST response at 6 months. Altogether, 32% had partial responses, 12 patients, 48% had stable disease, and 2 patients had progressive disease. And these were actually patients who were actually progressive at baseline. And here are examples. You can see this very potent redifferentiation effect in these 2 particular patients. The second cohort was patients who were RAS wild type but had RAS-like lesions. So these patients had either BRAF fusions or class 2 BRAF mutations. All 3 of these patients met the criteria for administration of radioactive iodine with 1 partial response. And of the RET fusions, 1 of 4 responded. And as Maria correctly mentioned, there are now anecdotal studies showing that RET kinase inhibitors hold a lot of promise for this patient population, and clinical trials are now being designed looking specifically at RET kinase inhibitors in the redifferentiation state. So if you look at it all together, this is an analysis that we froze last year. Since that time, we've actually completed a number of additional patients. So we had at this time studied 69 patients on redifferentiation trials. And of these, 34, that's roughly 50%, had received radioactive iodine therapy. And of these, there were 18 partial responses and 12 patients with stable disease at 6 months. And patients often ask, what is the longer term outcome of these patients? And this is the information we have so far in terms of time to subsequent therapy or death. So these are patients who are ultimately either at the time, we're looking at the time they required a second-line therapy or actually died of their disease. And you can see that they are different from each other in that those patients who received radioactive iodine did better than those that didn't. It is important to clarify that we do not necessarily view this as evidence of benefit. We believe it's likely to be the case, but it could also be that these patients have different intrinsic biologies, and the fact whether or not they receive and respond to radioactive iodine may be an epiphenomenon, and the other factors are driving their ultimate prognosis. So both possibilities, are still there. So there are a number of other groups who have done studies along these lines, and these are summarized here. These are the various trials that have been done. I did not incorporate the study I just mentioned now, which is our Trametinib study, but Sophie Leboulieu in France has also done a smaller series with Trametinib. And so these are overall the data. And you can see overall the partial responses that we are getting are something between 20 and 38%. And in the RAS context, the study I just showed you is also in the high ends of the 30% range. And at least there's a hint that dabrafenib and trametinib, the combination, may be a better approach for redifferentiation of BRAF disease based on the series that Sophie published as well, or Sophie completed. I think it's not published yet. So, of course, what we tend to measure in these is mostly radioiodine uptake, but what determines the ultimate dose that the tumor receives is not just the uptake, but the retention of the isotope. And that requires iodine to be organified. That means iodine needs to be incorporated into protein in order for it to remain in the thyroid cell. And in the mouse models that we studied, the BRAF mutant mouse model, for some reason, I'm sorry here, this slide has become a little bit corrupted. When we looked at the actual time course of iodine 124 lesional dose, what we found is that with the Chugai inhibitor, this RAF MEK inhibitor, there was a rapid decline in retention of iodine in the thyroid. But when we combine this with a pan-PI3 kinase inhibitor, we actually prolonged the retention time. So, and the reason that we believe that this is happening is because the PI3 kinase inhibitors restore in a better way the expression of the dual oxidases that actually are involved in the generation of peroxide, which is necessary for the thyroid peroxidase to incorporate the oxidized iodine into thyroglobulin. You can see that thyroid peroxidase is also increased by the combination. So based on this, Alan has designed a clinical trial with a very similar experimental design as all the other studies that we've been doing so far, which is a treatment period, which in this case has been shortened to only 10 days. And the reason for that is that this combination has a greater potential for toxicity. And we are still doing I-124 dosimetry to determine which patients ultimately get treated. This is a phase 1 study, which with increasing doses of vemurafenib and the pan-PI3 kinase inhibitor capanlisib, and that is currently in progress. So one of the things that became obvious in the vemurafenib clinical trial was that when we looked at individual lesions in the I-124 responders versus non-responders, no big surprise that in the non-responders, most lesions did tend to actually show increased I-124 SUVs. But we were interested in finding whether there were some factors that could predict which were more likely to respond or not in the BRAF context. And one of the things that was apparent was that in those patients who actually met the criteria to receive radioactive iodine, they tended to have a greater thyroglobulin level at baseline. In a way, one way of thinking about this is that these patients already had perhaps a more retained differentiation state, and that manifested with a higher thyroglobulin level. Of course, this is not corrected for tumor burden, so hard to know exactly how to use this information, but intuitively and also anecdotally, that is my sense that some patients who tend to have BRAF mutant thyroid cancers with low thyroglobulin, despite having significant tumor burden, are the ones that are least likely to respond. So I'd like to close with some thoughts about which patients are likely to respond and which are unlikely to respond. And I touched on that yesterday with conventional radioactive iodine administration, that is not patients sensitized with drugs to redifferentiate them. And what we found was that, no big surprise, RAS mutant or tumors tend to respond better than BRAF mutant tumors, and that some lesions, particularly those affecting chromatin remodeling agents, appeared to be, when they were present, appeared to prevent them from responding. And this is also the case for redifferentiation trials. And the category of genes we focused on, at least to do some functional studies to start with, is this complex called the switch-SNF complex or SWI-SNF complex. And what it actually does is it is involved in opening the chromatin to allow transcription factors to access it in order to regulate expression of differentiated genes. So, as many of you know, that our DNA is not essentially just a linear, set of nucleotides, but is actually, it's a tightly wound DNA that's wound around these nucleosomes, which are these histone proteins. And in this compact state, this DNA, you can think of it as largely inactive in that transcription factors cannot access this DNA to regulate gene expression. They can only access the areas where the chromatin is open. And what the SWI-SNF complex does is actually, it's an ATP hydrolyzing complex that actually has the ability to essentially unwind these nucleosomes and make this DNA accessible for gene transcription. So in the initial TCGA study of papillary thyroid cancer, there were very few patients that actually had SWI-SNF mutations. They tended to be subclonal, which is what you're showing here. But when you look at more advanced tumors, polydifferentiated or anaplastic thyroid cancers, they become clonal, and they also become more frequent. This is also true, as I discussed in the question and answer session of in the morning session, for TERT mutations. So when they're present in papillary thyroid cancers, they're subclonal, they become clonal in advanced disease. So these are genes really important in disease progression. And what do they do? So here again in the mouse, we modeled this by essentially creating deletion mutants of various components of the SWI-SNF complex. And what you're looking at here is the results of this chromatin accessibility assay called ATAC-seq. And so where you see these nice, deeper blue bars, these are areas of accessible chromatin that can be transcribed. But when you have loss of these subunits, you can see that chromatin is less accessible. And it becomes less accessible, in particular, at genes that are important for thyroid function. So the thyroid lineage transcription factors, as well as their client transcripts. So in blue, you can see the chromatin being closed, and in red being open. And as you can see in the wild type context, these are all open in the thyroid cells, whereas in the mutant context, they're all closed. So this translated to decreased iodine incorporation. I won't go through this slide in any detail, just to because I'm running out of time, but I just want to illustrate that among the patients in our clinical trials, in this particular study, which was a combination of vemurafenib and this HER3 monoclonal antibody antagonist with the same design that I've been describing before, we had two patients illustrated here. One that had a lesion that redifferentiated beautifully and that had a very nice restoration of the thyroid differentiation score. And this other one that had an ARID2 mutation of the SWI/SNF complex that did not redifferentiate and that failed to enhance the thyroid differentiation score with the combination of these drugs. And this was also true in several patients in our Trametinib study. None of the ones that had SWI/SNF mutations redifferentiated, whereas this, index case with HRAS and EIF1AX mutations did redifferentiate very nicely. So this is all I had. I do want to just mention the people that were involved with this work. Most importantly, the phenomenal clinical team that does the clinical trials on redifferentiation with Alan at the helm, the critical group of Steve Larson, Ravi Grewal, Keith Pentlow from the nuclear medicine department, without whom this would not have been possible, Mike Tuttle, the rest of our colleagues in endocrinology, and on the preclinical side, the work of the SWI/SNF complex mutations was done by Javi Garcia and Mahesh Saxena, and these were our computational colleagues. This is our support, and I thank you very much for your attention.